Welcome everyone to this Meet the Trialist session at ESC TV 2019 to discuss the results of the complete trial that was presented here and published simultaneously in New England Journal of Medicine yesterday. I am Stefan, interventional cardiologist from Uppsala, Sweden, and I'm joined here by the principal investigator, Dr. Shamir Mehta from Hamilton, Canada, good friend and colleagues and collaborator. Welcome, Shamir.
Thank you.
Can you start off by just briefly remind us what was the hypothesis, what were your findings, very briefly?
Sure. So the trial was a 4,000 patient randomized, multi-center randomized trial involving STEMI patients with multivessel disease. They were randomized to receive a strategy of routine staged non-culprit lesion PCI or optimal medical therapy alone for the non-culprit lesion. We were interested in looking at hard clinical outcomes because there were several studies prior that showed a reduction in revascularization. So we powered the trial to be able to detect reductions in cardiovascular death or MI. We followed patients long-term for a median of 3 years, and the longest follow-up, I believe, was just over 5 years in the trial. And the primary results showed a reduction of 26% in the risk of cardiovascular death or new myocardial infarction. There was a similar reduction, about a 50% reduction in the triple endpoint, CV death, MI, or urgent revascularization. And there was a reduction in myocardial infarction in the trial, new onset myocardial infarction. And we can talk about the types of MI that were reduced in the study. IDR was reduced, unstable angina was reduced in the trial. So overall, it met its primary objective, significant benefit of routine non-culprit lesion PCI and geographically guided.
Thank you very much. So this is obviously a very important trial addressing a common clinical question we have as interventional cardiologists.
Yeah.
As a large proportion of patients, maybe up 40 or 50% of them, do have some degree of non-culprit artery disease when we do our primaries.
Yeah.
So you're welcome to get up to the mics. There are 2 mics here. Welcome to come up. Always these trials give us answers to important questions, but they also raise questions, of course. And it needs to be interpreted in the context of our clinical experience and practice. So please go ahead.
Thank you.
Introduce yourself. And
Rajai Ahmed, UK interventional cardiologist. Can you just give us a rough outline of the proportion that were done at the indexed interventional procedure for the STEMI during the same admission and rehospitalization?
So you raise a good point. So what I didn't mention earlier was that randomization in the trial was stratified according to the intended timing of non-culprit lesion revascularization. So the investigator was asked at the time they randomized a patient, when do you intend on revascularizing the non-culprit lesion? Should the patient be randomized to that arm of the trial? And they had to indicate during the initial hospitalization or after the initial hospitalization. And the question was what proportion of patients were in each of those 2 strata. So 70% was within the initial hospitalization, and the median time to non-culprit lesion PCI was 1 day, and about 30% of patients were after the initial hospitalization, and the median time to non-culprit lesion PCI was about 3 weeks in that strata.
So that's an important question, and maybe we can extend it to also asking, because sometimes as interventional cardiologists, we're tempted to go ahead and do the culprit immediately.
Yeah.
And that question was not addressed, right?
No, we did not do the same sitting as the index PCI procedure. Having said that, the staged non-culprit lesion PCI, the median time was 1 day, which means about half of patients had it earlier. So it was fairly early, but not in the same sitting as the primary.
Because this colleague maybe is wondering, since the culprit shock trial was published recently,
yes.
And that was in shock patients with
Yes.
STEMI most of the time, and there was a hazard of doing immediate complete revascularization. How do you put that in context with these results?
That's an excellent question. We've obviously thought a great deal about it. So the first thing is that what we learned from COMPLETE, we learned a lot about staged non-culprit lesion PCI, but we also learned a lot about the time course of events in the two strategies. And most of the early events in patients with STEMI are probably a consequence of the size and the severity of the index myocardial infarction. And complications from the culprit lesion PCI itself, which is usually a very thrombotic lesion. So within the first 30 days, those are the endpoints that are dominated. And remember, both groups of patients had primary PCI, both groups of patients had MI. So in the early time period, the overwhelming number of events are dominated by the index PCI. And then we see the benefit of the non-culprit lesion over time. It's not an immediate effect that we're seeing within the first several weeks. It happens over time, and particularly after the 1-year time point. We see the increase in the separation between the two curves. Now, if you look at shock patients, they are at the extreme end of STEMI, and they have many events, about 50% mortality early on. And so they take this concept of early events to the extreme. So it's very hard to show a benefit of a non-culprit lesion intervention when the consequences of your index infarction are so high.
Yeah, so that's good comment. Please. Yeah.
Hi, Suresh Vijan, interventional cardiologist from Mumbai. Just a question, did you actually look at outcomes early as well as maybe at 6 months between the two groups that were done early in the index itself and others that were posted for 3-4 weeks down the line? Is there a difference or is there no difference?
So that's an excellent question, and my colleague, Dr. David Wood, my co-PI, will be presenting those data exactly at the TCT in about approximately 1 month from now. It's been accepted as a hotline presentation, and we will have detailed data, hopefully with a simultaneous publication, on the time course of events. So when did the events happen? And it was all pre-specified in the statistical analysis plan. So I don't want to steal his thunder, other than saying, or reiterating what I just said, is that the main benefit, the main value of a complete revascularization strategy is over the long term.
Thank you.
So please come up to the microphones if you do have questions. Otherwise, I have a long list of questions. So
my name is Pontus Lindros. I'm an interventional cardiologist from Stockholm. I'd like to congratulate the important trial, and I would ask you about the angiographic criteria for revascularization in your study, because it's eyeballing, right? Mm-hmm. And the following question would be, in context of other trials ongoing, like the full revas trial and so on, what would you expect when you add physiology to this patient group?
So that's a absolutely terrific question, and I'm going to ask Stefan to comment as well, because I'm sure he has a lot to offer. From our perspective, it comes down essentially to the pathophysiology of the disease. What is predicting outcome events in this disease? Is it unstable plaque, thin cap fibroatheroma, large lipid core, so vulnerable plaques that are predicting your outcome, i.e. are outcome events dominated mainly by the biology of the disease, or are they predicted mainly by the physiology, the anatomic severity or the consequence of ischemia? And we don't know the answer to that question. Our assumption when we did this trial was that it was the biology that was predicting the outcomes, and we based that on the large study that Greg Stone did, the Prospect trial, which suggested that it was the makeup of the plaque, the thin cap fibroatheroma, the large lipid core, and that it would not be possible for a physiology-guided approach to distinguish between, let's say, an 80% plaque that was biologically active versus an 80% plaque that was inactive. One plaque is atherogenic, is likely to rupture and cause events. The other plaque is probably stable. It's probably not going to cause an event. And how is physiology sorting out the difference between those two types of events. So we chose an angiography-guided approach. The physiology-guided approach also has some benefits, right? You don't have to do as many PCIs. And so if your intervention is risky or it's harmful, you may prevent early peri-procedural events. So that would be the advantage of a physiology-guided approach. I'll let you comment.
No, I agree. I think that's a very, very good comment. And the reason when we designed the full revasc, as you know, we based the enrollment on physiology rather than eyeballing, was to be able to avoid unnecessary interventions, and that could maybe contribute to risk and complications, and save it for those who actually would probably benefit the most. But I agree, there are also a need for better other methods, and we need to learn more about the plaque physiology and how to detect them and how to treat them in a preventive manner.
Yes.
And I was also a little bit skeptical when the first results came out from the first couple of trials, because preventive PCI have not been shown very beneficial in stable coronary disease situations. So it was a little bit difficult to predict a great benefit in post-STEMI. There's a question here from the audience.
Hi, my name is Guy Whitberg. I'm an interventional cardiologist from Israel. One data that you can extract from reading the manuscript yesterday, if you actually look at the average enrollment rate of patients per center, it's less than 1 per month. Now, that would suggest that these patients are much more highly selected than the inclusion criteria would suggest. And that was also a feature of all of the other culprit versus multivessel interventions, all of the other trials. So how could you apply the results of these trials to general clinical practice?
Yeah, so a couple of points. So when you look at the number of centers in the trial and then you look at the enrollment rate, it's a little misleading, because usually a smaller number of centers account for the bulk of the recruitment. Many centers, although they're activated, become inactive for whatever reason. They have competing studies, and they don't recruit for long periods of time. So it's a little misleading to think that recruitment amongst all of the 130 centers was equal. It probably wasn't. But having said that, this is a procedure where we did it an average of 1 day later. So there was a second thought about whether the patient should go into the trial, whether a patient may be too sick to go into the trial, whether there were other significant comorbidities that would put the patient at risk of having a non-culprit lesion PCI. So certainly there probably was some selection in the trial, but I don't think it was a large selection bias that we had. And remember, the critical inclusion criterion here is that the non-culprit lesion had to be amenable to PCI in the view of the interventional cardiologist. So we didn't want to go after lesions that were with a low likelihood of success. That was not the point of the trial.
I think before I let you in, I think you bring up such an important point with that question, because when we as clinicians want to interpret the trial, implement the results in our clinical situation, we have to understand the inclusion, exclusion criteria and selection, possible selection, because there's always some degree of selection, selected enrollment in trials. And one of the indication perhaps of selection that I'd like to ask you is also the interaction p-value analysis in the subgroups, looking at proximal LEDs versus non-proximal LEDs, which was not significant, as you would expect. And so first I can let you ask you first, and then I can comment maybe. What is the reason, do you think, that proximal LED was not a predictor of positive outcome in the trial?
So the outcomes were driven mainly by type 1 MI. So new spontaneous MI that occurred at various points across the follow-up period of up to 5 years in the trial. And so it's suggesting that the mechanism is a new plaque disruption or new plaque rupture. And so is a proximal LAD plaque more likely to rupture than a plaque, let's say, in the proximal right coronary artery? I don't think we know the answer to that. The thrombogenicity of any given plaque depends on so many different variables, but location is probably only one of those many variables that predict whether a plaque is going to rupture.
With respect to selected enrollment, I noticed that, can you hear me still? I noticed that there were relatively few patients with proximal LAD, which made me consider, was there a selection bias towards not enrolling high-risk proximal LADs? So the high-risk proximal LADs were not enrolled because physicians were not willing to enroll them, and therefore the highest risk proximal LADs were not included. So
we had we had approximately 10 to 12% of patients enrolled with a true proximal LAD lesion, right, as determined by the angiographic core lab. So often a mid-LAD lesion with a large second diagonal vessel, for example, is equivalent to a proximal LAD lesion. But if we use the true criteria as defined in the angiographic core lab, it was about 10% of patients. This was a 4,000 patient trial. So we're talking about 400 patients, which is about as big as some of the earlier trials asking this question, and that involves only proximal LAD lesions. So it's not a trivial number.
Please.
Just to, can you hear me? Just to confirm, in terms of assessing, so you're talking about any lesion that's 50% visually, and what about CTOs? What was the?
It was.
How were they tackled?
Can you repeat, Shamir? Can you repeat the question?
The question was 50%.
A visual assessment, 50% stenosis in any lesion.
It was 70%.
70%.
Yeah, the cutoff was 70%. If they had a lesion between 50 and 70%, they had to have a positive FFR.
So some patients
it had to be an FFR of less than 0.8 if they were in the 50 to 70% lesion. But very few patients, less than 1%, had stenoses less than 70%. The majority, overwhelming majority, was over 70%.
And if they had CTOs as non-culprit?
CTOs were not an exclusion criteria in the trial, so they were allowed to be included in the trial. Approximately 2% of patients had a CTO in the trial. The protocol specified that if a patient with CTO was to be enrolled in the trial, there would have to be a high likelihood of success as determined by an expert CTO operator. If that criteria was met, then the CTO was eligible to be included in the study. It turns out we only had 2%, and we haven't looked at the data yet, but we will be looking at the CTO data in a lot more detail. And don't forget, we have an angiographic core lab, so we can look at things such as JCTO scores, we can look at the outcome of the CTO, we can look at all sorts of parameters relating to the CTO that will hopefully help shed some light on whether we should be doing them as routinely as non-culprit lesions.
I mean, that 2% suggests that maybe there was some selection as well, and they were excluded.
It's possible, but remember that
it's much lower than
in the situation of STEMI. This is not non-STEMI, this is STEMI. So these are younger patients, mean age is only 61. In a large majority of patients, this is their first manifestation of coronary disease. Many of these patients had never even seen a physician before. They're coming into the hospital with their first manifestation, so they were never on any treatment before. There's a high proportion of smokers in the trial. So if you look at the baseline syntax score, it's not that high, not only in this trial, but in any STEMI trial. Baseline syntax score is in the range of about 15. It was about 16 in our trial. And that's just the nature of STEMI versus, let's say, non-STEMI or a chronic CAD population.
Okay, thank you.
Just to expand on that question and for the audience to understand the different cut points here. So the trial included patients with a stenosis more than 70% by eyeballing, or between 50 and 70% by FFR.
Correct.
And there was a subgroup analysis looking at stenosis level above 80%.
Yes.
That had a significant interaction, meaning that there was a greater benefit in those with tighter stenosis versus less tight stenosis, right?
Absolutely, yeah, that's correct. So we predefined only 4 subgroups in the trial. Those were the 4 main subgroups that we were powered for, And then we had many other predefined subgroups, and you can see in the New England Journal paper, they're all there. But amongst those 4 main subgroups, one was the timing, one was proximal LAD, one was residual syntax score, and the last one is the one that you pointed out, was the stenosis severity. And we chose 80% because 70% was the criterion to get into the trial. And we really wanted to know, was the benefit more so in the patients with tighter lesions or less tight lesions? So we chose 80%. And as you said, there was a significant interaction. For both the first co-primary and the second co-primary, showing a preferential benefit in patients who had tighter lesions.
Please.
Thank you very much, Dr. Mehta, Dr. James. Groundbreaking research will change our practice. I may have, I missed the first couple of minutes, so I may have,
Sure.
my question may have been answered. It's just a safety issue, because I mean, it's, I think, you know, now practice is going to change, and there might be some pressure on some younger cardiologists to do everything there and then. So a couple of practical points. I mean, would you generally recommend that everything gets done on the index procedure unless the patient is too sick and...
Index hospitalization,
yeah.
not procedure.
Oh, not the procedure?
No.
Okay.
No, it was a staged PCI approach we took.
So the majority did not undergo the culprit lesion during the index procedure?
No.
I mean, for me
no,
as a
they did not.
radialist, this is an issue. It means I have to do 2 radial punctures, which is something that I'm not terribly happy about. Why not do it there and then, unless the patient's not doing well?
Yeah, I mean, that's a separate question as to whether or not you want to do it during the index procedure itself. But as you started your question about, you know, the issue of safety, there were some issues of safety about going after a non-culprit lesion during the index procedure that were unknown. Remember, the trial was started 7 years ago. So we thought we would look at the timing in a different way, so early stage versus later staged.
Okay.
We didn't find any downside to doing later staged PCI, except for perhaps cost, and we'll have a cost analysis coming out because it's a separate admission, it's a separate procedure. But we saw no downside of going earlier at 1 day. Now, can you take that further and do it during the index procedure? Maybe you can, maybe you wouldn't. I would ask you, why would you?
It's just...
You know, the goal of, remember, the goal of primary PCI is not to open the non-culprit lesion, right? The goal of primary PCI is to abort the infarct, is to restore flow to the myocardium and restore the infarct. That's the goal of primary PCI. It has nothing to do with the non-culprit lesion.
I have
Now,
a real issue with double access in a couple of days.
That's a smaller issue. I think access is a smaller issue than a risk during the PCI itself. The other point is, that I've made before and that we started with, is that the benefits are not early. So there's no rush, and there should be no pressure. Okay. There should be no pressure to go after lesions during the index procedure. I think that would be a bad takeaway message if people left thinking that from this trial.
Thank you.
Safety is very important, and it's the utmost importance for the patient. So I think now we'll have trials looking at a same-sitting approach, but I can tell you that the benefits are unlikely to be early on hard outcomes. Maybe revascularization will show a difference because it's open label, patient knows, physician knows, but for hard outcomes, we're looking at long-term benefits.
Well, thank you for that
Thank
question.
you.
I think it's important to point out that was not addressed in the trial, and currently we don't have any trials that actually recommend same-sitting non-culprit lesion interventions, but it's not been investigated in this particular setting. Yeah. Please, next.
We have 5 trials now. The Premier, Culprit, Dynamic, Compare, and 5. And then they're changing the guideline. In the beginning, they said that complete revasc, then don't do non-culprit, and now this recommendation to be index. I'm doing the same after changing the guideline, even a thrombectomy the same. Yeah. But what's your explanation between the different trials? What at the beginning, it's okay for the complete, and then change it to be not doing the... It is underpowered, it is ejection, it is the number. We can make another trial after another randomized trial for more inclusion criteria. What do you think about it?
Well, I think, you know, Stefan James gave the commentary yesterday on our trial. and addressed exactly that. And he showed the prior trials and the consistency of all of the prior trials addressing this question on the endpoint of revascularization, which they were powered for. They weren't powered to look at the hard outcomes. So in complete we were. So we showed a reduction in the hard outcomes, but very consistent reduction in the revascularization outcome as well.
Okay.
Are there further questions from the audience? We can have one fairly quick question, then we're running out of time.
Thank you very much. In patients who were staged, what is the percentage of those who came on the next procedure and were deemed not to have a significant lesion, at least in these patients who were visually estimated?
So if you look at the New England Journal paper, you have to go to nejm.org, open the paper and click on supplementary appendix. You'll see that data in figure 1 of the supplementary appendix. It's right there. I can't remember the exact number. It was, I think it was in the range of about 15, but check the paper to be absolutely certain of the exact number. It wasn't 0.
It's just the observation sometimes that often you would estimate it to be severe.
It happens.
And then the staged, it looks less severe because
they
of
come
the
back
catecholamic surge, etc.
Yeah, it did happen. It didn't happen often, but it definitely happened.
So we're coming towards an end of this session. I'd like the audience for your active participation. I would like to thank Shamir for once again contributing with very important scientific information for the community that would change the way we practice. You have received a painting.
I just want to show people this because this was painted for us, the complete trial steering committee, executive committee, by a very famous cardiologist, Dr. Mike Gibson, who has, he's been a luminary in the area of cardiology. And talk about talent, this is absolutely incredible. So my thanks goes out to Mike for doing this. We're very touched by it. So I just wanted to say that.
Thank you very much again for contributing.